So again, thank you again for having me. And again, this is a very exciting moment when we have gene silencing to aid us in our options to treat resistant patients with hypercholesteremia. So this is my content of the talk. I'll be spending some time talking about the regulation of the LDL cholesterol by the Ldl receptor and PCSK9. So I have a small cartoon here so you can follow. This is PCSK9, this is the cell surface LDL receptor. And then I would shift gears to protein synthesis that involve in PCSK9 making. And then I'll be talking about mechanism of action of inclisiran, and then dosing and pharmacokinetic of inclisiran. So let's get started. So the story of lipids includes 11 Nobel Prize. The story started in the 1700s with the discovery of solid cholesterol and gallstones. And then the early basis of lipid hypothesis in the 1900s by the discovery of lipoproteins. And then the major work of the father of clinical biology, John Goffman, that started the large population studies such as the Framingham study in the 1950s. So this is the plasma LDL, or low density lipoprotein cholesterol. And then a breakthrough where the Ldl receptor, discovered by Goldstein and Brown in 1974, followed by work of Akira Endo and Nabil Serra, which marked the birth of statin therapy and PCSK9 inhibitor. So let's discuss the Ldl receptor and how it's involved in the cycling. You have here in blue the Ldl cholesterol, and here in purple the Ldl receptor. LDL receptor resides on the liver cell. So the LDL receptor binds to the LDL cholesterol through ApoB, and together they internalize by the endosome with the aid of the glycerin-coated vesicle. Together the complex fuses with the endosome where the pH is lowered, and then the LDL receptor escapes the liposomal degradation and goes back to the surface, while the lipid content is hydrolyzed and used by the cell to produce hormones and recycled back. So this process or this journey is the Ldl receptor cycle, and this is how your statin, which upregulates the Ldl receptor on the surface of the hepatocytes and uses reduction in cholesterol in the blood. So adding another facet of the story is the PCSK9, or the proprotein convertase subserine cysteine type 9, which was discovered in 2003 by Dr. Nabil Serra and his group. The PCSK9 is synthesized by cell the same way as the Ldl receptor. However, the PCSK9 circulates in the blood and binds to the Ldl receptor like a glue. So through a protein-protein interaction, it holds the two complexes, the Ldl receptor and the LDL cholesterol, together tightly. So when the whole molecule goes through endosome, the LDL receptor is unable to escape the endosome and the lysosomal degradation and unable to resurface back to the surface of the hepatocytes. And this will decrease the level of the LDL receptor, and therefore you will have high cholesterol in the blood because your LDL receptor cycle is inefficient. So this is coexists with mutation in different population, in different individuals, where you have gain of function mutation in PCSK9, where you have high level of PCSK9 or high affinity of this molecule to the LDL receptor. This again will help, or this will induce degradation of the LDL receptor, reducing the number of LDL receptors on the surface, which decreases the LDL receptor uptake and therefore increase the plasma cholesterol in the blood circulating. And this is the cause of familial hypercholesterolemia, other than the mutation in the LDL receptor. So it is similar in phenotype. And also exist loss of function mutation in healthy individuals. As you can see here, this is from the Dallas group led by Cohen, where he found that his population, they have a normal Gaussian distribution in terms of plasma cholesterol. However, his subset of population with loss of function mutation in PCSK9, the distribution was skewed toward the left with lower level of plasma LDL cholesterol. So this proves that loss of function mutation that leads to enhancing of the LDL receptor recycling and therefore lower level of cholesterol. And this, of course, together improve the cardioprotectiveness of individuals. And as you can see, compared to the normal population, loss of function mutation in PCSK9 have a lower level or lower incidence of coronary heart disease. Of course, this was a breakthrough and became a therapeutic target. And it also coincided, or it happens to be a revolution in advanced biologics, where they have now have more less immunogenic and more fully humanized monoclonal antibody with an excellent profile. And this was used to neutralize PCSK9. And this have together modernized the management of hyperglycemia forever with the introduction of novel therapeutic target approaches with elecromab and ivacimab that was given twice monthly as injection, subcutaneous injection, and reach level of LDL cholesterol, which was not achieved. So let's rethink this approach. Now we are targeting the protein level with monoclonal antibody, but can we stop actually making PCSK9 instead of targeting the downstream, which is the protein level? So can we inhibit messenger RNA and stop the protein from being produced? So this is the second part of my talk, where we discuss the gene protein synthesis. So the dogma of genetic is the DNA stores all the genetic information for your protein enzymes, and through the process of transcription, you make messenger RNA from your gene of interest. And through the translation, or when the messenger leaves the nucleus to the cytoplasm and meets the ribosome and meet the RNA polymerase, it makes the protein. So this is the dogma of genetic for many years. Another discovery by Andrew Farr and Craig Mello, who won the Nobel Prize for Physiology and Medicine for the discovery of RNA interference. So where does the RNA interference came from? Actually, it's a natural biological pathway where the non-coding region of the whole of the genome produces, again, RNA that are not encoding for any protein. So they discovered later on that this non-coding region produces regulation, another step of regulation of our protein by silencing different genes using synthetic short interfering RNA that targets a unique messenger RNA nucleotide sequence and can theoretically target a gene of your interest. So introducing short interfering RNA, you stop the messenger RNA from producing protein of interest. So this is very highly specific because you use base pairing that complement or for your specific messenger RNA for specific protein. So this is again a breakthrough. Now is being applied for different diseases, even coronaviruses. Now they're talking about increasing drug selectivity, and they're applying it for different diseases, and they have specific conferences for it to treat liver, CNS, and other diseases. So how does it happen naturally? So the natural cellular process involves, first of all, you make your messenger RNA from the coding region, and you make your double-strand RNA from your non-coding region. And through a molecule called dicer, it will shorten your double-strand RNA. So your RNA from the non-coding region coils back to form a double strand. The dicer, what it does is shorten this double-strand RNA, to make short interfering RNA. Then the short interfering RNA is targeted by something called the RNA-induced silencing complex, or RISC for short. And through an enzyme called arginate 2, this enzyme cleave the targeted, degrades the passenger strand of the short interfering RNA, because the double strand contain both the targeted and the passenger strand. So one is called targeted, the other one is called the passenger strand. So the guided strand direct the RISC complex to a specific messenger RNA through a complementary base pairing. So your messenger RNA now is complex with the RISC and the guided strand, and again through the arginate 2 is degraded. So with this mechanism, you can down-regulate your messenger RNA and down-regulate your protein synthesis. So this is the natural cellular process. Now I'm going to talk about the mechanism of inclisiran, which uses this natural process in your body. Through synthesizing a small interfering RNA or small RNA, you will mimic the natural process. However, we have a problem, because all the studies and all of the trials, the previous trial that has tried small interferences, were failing, because basically you didn't have a deliver mechanism, because the short RNA becomes vulnerable to different endonucleases and exonucleases that degrades it very fastly. So all attempts were failed. Therefore, they came up with different technology. Either you conjugate it to enhance, to protect it and guide it, or you incorporate it in lipid nanoparticles or liposomes. So inclisiran used this technology using conjugated galactine or N-acetyl galactosamine. So this is our molecule. Again, it's 21 to 23 mer double-strand RNA. So you have both your guided strand and you have your passenger strand. Your passenger strand is conjugated with phosphorothioate to help it stabilize and protect it from exo and endonucleases. And at the third prime of your passenger strand is conjugated with galactine or N-acetyl galactosamine. So this modification helps the double strand, first of all, escape exonucleases. It behaves as a pro-drug because the passenger protects it until it's activated. And the galactine functional group targeted to the liver, because there is a receptor called acyloglycoprotein receptor, which is ubiquitous in your body. However, it's concentrated in your liver. So this helps it enrich or uptake by the liver specifically. So tissue-specific targeting the drug. So the mechanism of action, again, you have your LDL cholesterol circulating in the blood, PCSK9, which is synthesized the same way your Ldl receptor is synthesized, is excreted by the cell, binds to the PCSK9 binds to the Ldl receptor, and once your Ldl receptor binds to the LDL cholesterol and internalized, it cannot escape the degradation through the lysosome, because PCSK9 promotes the degradation of the LDL receptor. Hence, the LDL receptor is down-regulated on the surface of the hepatocyte and not allowed to efficiently recycle and lower the cholesterol in the blood. Through this drug, inclisiran, which is, again, a silencing technique, protein silencing technique, your inclisiran binds to the acyloglycoprotein receptor that is ubiquitously present in the hepatocyte and concentrated in this tissue where you need it the most. When it joins the endosome and your pH drops, the conjugate is now released, and the double strand slowly released from the endosome and allowed to join the RISC complex. Now, when it joins the RISC complex, the passenger strand is degraded by the arginylate 2 again, allowing it to now target the messenger RNA encoding for PCSK9. Once it complementary pair, now arginylate 2 again degrade PCSK9 messenger. What it does again, and finally, it relieves the Ldl receptor from being degraded and helps the efficiency of recycling and helps drop the cholesterol in the blood. So this is the novel, both the novel mechanism and the novel therapeutic delivery of the molecule. So at the end, I will talk about the dosing and pharmacokinetic and safety of this drug. Of course, it's injectable. So it's about 1.5 ml of solution per syringe, about 300 milligram of inclisiran molecule sodium is diluted in water, and the pH of the whole solution is about 7, and it's stored in room temperature. It starts with an initial dose to saturate all the endosomes, followed by a second dose in 3 months, and then every 6 months. It's administered subcutaneously in the abdomen, and then it diffuses in the blood. So the metabolism includes the slow degradation by the liver exonucleases. Again, as we said, the whole molecule acts as a pro-drug because the passenger strand binds to the guided strand and slowly disassociate. Both strands goes through a very slow process of nucleoside degradation from the 3' to the 5' end, and they join the hepatic nucleotide pool. Later, they are eliminated by urobile. They peak in plasma, the molecule in half an hour, appears in half an hour and peaks in 4 hours. And the level declines after 24 hours, and it's undetectable after 2 days. It's concentrated in the liver in about 8 hours because it's absorbed by the acylglycoprotein receptor that is present in the liver. And then it presents its action by targeting PCSK9 messenger RNA through RNA interferences. Again, inclisiran passenger and guided strand undergo slow exonucleases, and this is why the drug is stays in the system or in the liver for a very long time. It does not go through the cytochrome P450, so we don't expect any drug-drug interaction. The main route of elimination is the kidney. However, the absorption is very low compared to the liver, and 16% of inclisiran cleared through the kidney in the half-life about 9 hours. So the safety and pharmacology and toxicology of the drug. So there is no drug interaction because it doesn't go through the cytochrome P450. So we don't expect it has any drug-drug interaction with atorvastatin and not cause any associated toxicity. There's no genotoxic or carcinogenic effect, and there's no expected off-target toxicity. At least in primate and animal model, it didn't affect any fertility or embryonic development. Still, it's considered a drug that's not given to pregnant ladies or lactating. There are no need for drug adjustment in renal failure or hepatic impairment. And the only side effect that have been observed, like any injectable, is the injection site reaction. So with this, I have to conclude with this summary or summary. So inclisiran as a small interfering RNA to lower cholesterol and present a novel mechanism of action. Twice yearly subcutaneous injection is a novel regimen with an excellent preclinical pharmacokinetic and toxicokinetic profile. The drug now is European approved and soon will be Saudi FDA approved, and it's undergoing post-marketing study for post-marketing safety as we're going to see in the Orion development program. With this, I conclude, and I will hand it over to Prof. Khalid Al-Habib to talk about the clinical trials.
Thank you very much, Professor Zuhair Awan, for excellent review of the mechanism of action of the small interference RNA drug, namely inclisiran. It has been really very thoroughly and elegantly explained by you. I'd like to thank you very much for setting the stage for me to talk more in depth and deep dive into the clinical trials. So deep dive on small interference RNA as a revolutionary approach in LDL cholesterol management. This is my disclosure. And I'd like to start quickly by 4 facts. Fact number 1, we live in an area, in a region with high burden of cardiovascular disease, very high risk population, unfortunately, because of very high rates of diabetes, dyslipidemia, obesity, low fitness and low exercise, and urbanization of the lifestyle, unfortunately, leading to premature cardiovascular disease at a younger age compared to the Western population. Myself and others have led and co-led many registries on acute syndrome and heart failure, and we have shown again and again in the Saudi Arabia and the Gulf region, and also in the Middle East, that we have cardiovascular disease that happen at 10 years younger relative to the developed countries in the West. Fact number 2, it's important also to mention and be cognizant of the facts, not only one snapshot LDL level that makes a difference, it's the cumulative exposure to the LDL cholesterol over the years in your life and my life that makes a difference. And it's important to remember this in our patients. It's not only important to get focus on 1 or 2 levels of LDL, but to make sure you have a sustained level over the years, not to have some sort of a zigzag levels of LDL, because that will lead to increased cardiovascular events in the future. The third fact that has been shown again and again in registries in our region and internationally, that we tend to undertreat the high-risk patients. 60 to 80% of patients who are at high risk, whether they are defined as those already have atherosclerotic disease, MI, angina, stroke, peripheral arterial disease, or familial hypercholesterolemia, heterozygous or homozygous, or those at high cardiovascular disease risk, for example, diabetic, hypertensive, smokers, and so on, those who are more than 20% risk in the next 10 years, we tend to undertreat them. And the reasons for this are many. Is it because we tend to give lower doses? Patients develop side effects, statin intolerance, the drug is not available in your center, and so on. So many reasons for this. Been many registries, the DICES Middle East, the CEPHEUS in our region, the Da Vinci registry by Cossack Ray and others have shown this many times. So we, despite a very high burden, we tend to not to reach the target in many patients. And recently in our Gulf familial hypercholesterolemia registry that we published recently, we shown also the same thing, that we were really way and away from the target when it comes to reaching the LDL target, despite using statins and ezetimibe, and the uptake of PCSK9 inhibitors is still very low, and we tend not to use the highest doses of statins even in these very high-risk patients. And the fourth and last fact, that then the implication for this, that we need an urgent need for not only effective but also sustainable LDL reduction over the years. So Zuhair made my life easier, so I'm going to go very quickly and swiftly over this. That basically, unlike statins, that basically just upgrade the LDL receptors, the PCSK9 inhibitors work on the monoclonal bodies, having the LDL receptor more available on the surface of the hepatocytes, so more LDL degradation, and the small interference RNA works at the very beginning. Cossack Ray makes the analogy of turning off the tap rather than just using a bucket like a monoclonal antibody, and every now and then you just clearing the monoclonal, the PCSK9 by monoclonal antibody from the blood. You're working at the small interference RNA, so more effective way of dealing with the LDL cholesterol at the synthesis mechanism. This has been shown elegantly by Dr. Zuhair. The inclisiran, the main magic behind it is basically this tail, the gynac or glycosamine that is available at the end of the strand that basically bind specifically to this receptor, the glycoprotein receptor in the hepatocyte. That's why it's taken exclusively in the liver. That's why in 24 hours and 48 hours, you're not going to find inclisiran in the blood. So it's very specific and avoids the systemic side effects that usually happens with drugs of such nature. So this is the novelty in such a drug. Those finding regimens have found in that such in this trial that it's the 300 milligram gives you the best reduction, or around 41%, and compared to 200 and very similar to the 500. And better than the 200 and the 100 milligram, achieving 50% reduction in the LDL cholesterol. So going now to the main objective of my talk, which is what is the clinical evidence. We have the Orion program, Orion 9 and 11. Orion 9 focus on heterozygous FH with LDL cholesterol more than 100 milligram per deciliter. Orion 10 in the US, mainly on or only in atherosclerotic disease patients, and LDL cholesterol more than 70 milligram per deciliter. And Orion 11, that basically was in Europe and South Africa, was in patients, combination of patients and a mixture of patients between those with atherosclerotic disease and those with atherosclerotic disease risk equivalent, meaning type 2 diabetes, or 10-year risk more than 20%, or heterozygous FH, LDL cholesterol more than 70 milligram per deciliter in those with atherosclerotic disease, or equivalent to or more than 100 milligram per deciliter in risk equivalent patients. This is the summary of the findings that in Orion 10, the US, around 1,500 patients, 51% reduction with inclisiran, and in Orion 11 in Europe and South Africa, which is a mixture of patients, as I told you, atherosclerotic disease and atherosclerotic equivalent patients, 45.8% with inclisiran. And these results were published last year in April in the New England Journal of Medicine in 2020. To go into more deep dive on the Orion 10 and 11 program, 18 months observation. This is it's a randomized one-to-one inclisiran, 300 milligram versus placebo with maximally tolerated statins. You give the injections at baseline and then the booster dose at 90 days, and then day 270 and day 40. And this is end of study day 540, 90 days post last dose. These are the inclusion criteria and exclusion criteria. The inclusion included adults more than 18 years of age or more, the atherosclerotic cardiovascular disease or risk equivalent in Orion 11, and those, to emphasize, the maximally tolerated doses of statins, ezetimibe allowed. So these patients were given plus minus ezetimibe. All of them give ezetimibe, and the LDL cholesterol inclusion, as has been mentioned before, more than 70 and more than 100 in those with risk equivalent. These are the exclusion criteria shown in the table. So to confirm the efficacy and safety over 18 months, these are the study endpoints. It's a co-primary endpoint. So percentage LDL change versus placebo at 510, an average over days 90 to 540. Secondary LDL cholesterol change over time and change in PCSK9 and other lists. The safety and tolerability are also has been measured, and exploratory analysis for cardiovascular events. So it's important to emphasize that these trials are not powered for clinical to show clinical benefit. However, it has been really as a hypothesis generating has been shown to report the results on these. These are the demographics. The table 1, the average age is 65 in each group, well balanced in randomized trials. And this is the Orion, the United States, patients from the United States, 44%, male gender, 68%, diabetes, 35%, and the lipid management treatment on 95%, statins, 92%, ezetimibe, 14%, LDL cholesterol line, 111, 112, and inclisiran. So very well-treated patient groups and very aggressively treated already on well-proven therapies. And the results showing that the inclisiran in both co-primary endpoint, the mean at day 510 and the time averaged day 92, 540 to show the sustained sustainability of the reduction was around 50% with very highly significant p-value. You can show this also in a figure diagram. The time average 52% and the absolute reduction, or rather the 55% reduction between both groups, the inclisiran and placebo over 18 months. And this is summarized in these graphs in both Orion 10, Orion 11, both randomized controlled trials published simultaneously in the same manuscript in the New England Journal of Medicine last year in those with atherosclerotic disease or risk equivalent. How about adverse events? There was no increase in the rate of diabetes, something that is, although uncommon, but happens with statins, as you know. No increase in upper respiratory tract infection, hypertension, arthralgia, some site infection, and the site-related reaction, has been shown in with other in PCSK9 injections, but mild and unsustainable. No increase in liver enzymes or kidney or any effect on liver, kidney, muscle, or platelet functions. No reported serious events in terms of affecting the cardiovascular events. And it's important to note that slightly less events in the inclisiran group. However, the study was not powered to show a benefit. So this is Orion 10 and 11, and Orion 9 focused on the other high-risk patients, the heterozygous familial hypercholesterolemia. Again, Cossack-Ray and the group from different parts of the world. And again, I don't need to go over this, but heterozygous FH is very common. 1 in 250 patients with heterozygous FH, we have shown in our region that is more common, 1 in 112, so almost double to triple the prevalence reported worldwide. And these are the inclusion criteria in Orion 9. Again, adults, 18 years of age, or heterozygous diagnosed FH, diagnosed by genetic testing and or Simon-Brun criteria, with LDL cholesterol more than 100 milligram per deciliter, which is equivalent to 2.6 more per liter or more, stable and low-fat diet, maximally tolerated statin doses, ezetimibe allowed, and informed consent. And these are the exclusion criteria. And these are the injections, again, very similar to Orion 10 and 11 at day baseline, and then day 90, day 270, and day 450, and end of study day 540, so 18 months study. This is the diagram of randomization. 482 patients randomized to either placebo or inclisiran, with excellent 96-97% follow-up over 18 months period. This is the demographics. The average age is as expectedly younger, relatively younger to those with atherosclerotic disease, 56, male gender 48%, and those with atherosclerotic disease around 30% in placebo and 24% in inclisiran. Again, very well treated patients on statins, very high proportion on statins already, 90% or more, almost 50% or more on ezetimibe, and their LDL cholesterol baseline is 155 milligram per deciliter, 151 in inclisiran, again showing that many of these patients are not well controlled despite being on high dose of statin and ezetimibe. And you can see the same findings, a great reductions in timed averaged 45%, and the reduction of 50% or equivalent to 70.6 milligram per deciliter between inclisiran and placebo on heterozygous patients. And in the secondary endpoint of the different genetic variants, great reductions in the PCSK9 and other variants as well. Safety results, there are no safety concerns again. Again, apart from slight increase in injection site reaction, which is mild and unsustainable. And this is in summary, the absolute LDL reduction and the change in the LDL cholesterol level. So we get that sustained reduction over 18 months, despite only taking very few injections compared to the other PCSK9 inhibitors. People ask, and Zuhair talked about this, dose adjustment. There is no need for Orion 7 showed no dose adjustments of inclisiran are necessary in patients with renal impairment. And another bonus you get with inclisiran that you have 20% reduction in lipoprotein Ldl, as has been shown with other PCSK9 inhibitors, unlike the statins, which do not affect lipoprotein Ldl, if not even slight increase. So it also a reduction in lipoprotein Ldl, which is an independent predictor for the atherosclerotic cardiovascular disease. And the benefit has been shown across pre-specified subpopulations, no matter what the ages and race and the baseline treatment, statins or not statins, and metabolic diseases and so on. Great reduction around 50%. And the studies and the two programs, or rather 3 programs, Orion 9, 10, and 11, Orion 9 in heterozygous FH, and Orion 10 and 11 in atherosclerotic disease and risk showed met the primary endpoint of reduction of 50% in the LDL. Now we're waiting the cardiovascular outcome trial, Orion 4. This is a design of 15,000 patients, lipid-lowering therapy optimized by their doctors and randomized 1-to-1, double-blinded to inclisiran 300 milligrams subcutaneously versus placebo. Again, around month 3 after the baseline injection, and then every 6 months. Median duration of follow-up 4 to 5 years, and the primary endpoint is CH death, MI, stroke, or urgent coronary revascularization. As I mentioned before, there was exploratory endpoint of major adverse cardiovascular event reduction by inclisiran in the previous Orion programs, but again, as has been shown in the figure, but again, this is hypothesis generating because these studies were not powered to show major cardiovascular outcome benefit, but it is reassuring that it is in the right direction as expected. However, important also to ask, are these benefits sustainable beyond 18 months? And yes, it does. So there is no loss of effect over 3 years, which is very assuring. So the same reduction of more than 50% or more beyond 18 months. So with the inclisiran, you get the additional lipid lowering of LDL and also the sustainability of the LDL over months and years. This has been shown already by Professor Zuhair, the way to inject and how to inject and so on. It's important to emphasize that this drug should be given in the clinic. So not unlike the other PCSK9 inhibitor, not to be given at least at this stage for the patients to give themselves at home. So to make, because these are just twice yearly injections. So you want to really make sure that it has been given properly in the clinic. And probably where we're going from here, as has been shown by Cossack Ray and colleague in Circulation last year, that we're going and changing paradigm from high potency statins to be given to a lot around the year, to just twice injection of monoclonal antibodies to PCSK9 twice a month, to twice a year with small interference RNA. And maybe in the future, we're looking at vaccination, similar to COVID-19 vaccination, maybe with gene editing. As Zuhair mentioned, we'll live a very exciting time as well, where maybe once in a lifetime, you get an injection and you get sustainable reduction of LDL in your life. So you don't need to go over a lot of pills and injection. So a great time to live in, and so far has been shown to have great results and safety. So to conclude, LICView or inclisiran is a novel small interference RNA that produces substantial sustained reduction in LDL cholesterol by mimicking naturally occurring partial loss of function variants in PCSK9 gene. Inclisiran reduces plasma LDL cholesterol by reducing LDL particles through the LDL receptor. So we still need the functioning LDL receptor. Those with homozygous FH with null receptors or not functioning at all, null receptors will still not respond to this drug, although I would guess and believe it's worth a try in some homozygous FH patient, because some of them might not have complete loss of function. So they have some sort of dysfunctional LDL receptors, and shares the same common final pathway for reducing the LDL cholesterol as other agents. And hopefully it will reduce the cardiovascular events in future trials. So far has been shown to be safe and effective, and a great potential to transform cardiovascular medicine by providing the first convenient method to produce substantial sustained reduction in LDL cholesterol over time, and the potential to dramatically reduce the lifetime risk of atherosclerotic events by reducing cumulative lifetime exposure to the main cause of atherosclerosis. This kind of approach has been shown, and as Zuhair mentioned, in COVID vaccines, and has been shown in porphyria and amyloidosis. So a great and exciting time to see it applicable as well in the treatment of dyslipidemia. With that, I would conclude and then open it for discussion. If you have any questions for us, myself, and Professor Zuhair Awan, please pose your question in the Q&A section. So maybe I'll start with the first question to Zuhair. How do you see this fit into the guidelines? If you imagine yourself a member, Zuhair, as part of the guidelines, where would you include it at this stage in the guidelines, or would you still wait for the cardiovascular outcome trials?
Yes, Dr. Khalid. Indeed, this drug is pending approval from the Saudi FDA approved committee, and once it's approved and the post-marketing safety profile has cleared, I think it's going to be used as the same way as PCSK9 inhibitor is used for patients who are not reaching the target using a maximum tolerable statin and ezetimibe. You would add in PCSK9 modality, whether monoclonal antibody or short interfering RNA. Hence, in the future, I think it could be moved to first line once you discover or you know your patient will not respond to statin or intolerable to statin. So again, the same way we use PCSK9 inhibitor, we will use more often we're going to use short interfering RNA.
So despite some people argue, like the devil advocate here, say, well, do you still need cardiovascular outcome trial? Why not use ones already proven and shown, like PCSK9 inhibitor? And then once you have the trials, which will be in a couple of years at least, then you can use this drug. How do we argue against that?
This drug has passed first and second and third clinical trial. With any drug, we don't reach the absolute potency of the safety until after a few years. So this is not I don't think it's going to stop us from using the drug once we pass all the requirement of the Saudi FDA approval. I think it should be you should be starting using it, and then like any drug, you report any side effect. You don't want to keep a very promising medication for your patient, especially if it has a very first of all long half-life and very simple and effective.
I just had a patient, Zuhair, 35-year-old lady with FH, familial hypercholesterolemia. Her LDL is 8, and her two daughters have high LDL, although not as high as hers, around 4.5, 5 point something, 13 and 15 years of age, and very thin. So very extremely high risk patient. So already has FH. Came to me with a rosuvastatin of 4, and her LDL dropped from like 8 to 6. This is the other problem that people in the public do not know, that doctors still undertreat these patients and do not understand these patients get exposed from their live birth to that LDL. So I added ezetimibe to her, and I added a PCSK9 inhibitor twice a month in the last 2 months, and her LDL went down from 8 to 6, as I told you, and then from 6 to 1.5 in 1.5 months. Obviously, I had to convince her to take 3 drugs for cholesterol. And once I told her about the inclisiran, that you do not need to take the, this is an option to you, if you want to switch to twice a year kind of a drug like inclisiran, would you go for it? Because she achieved a target with the 3 medications. I cannot force her to at this stage to switch to inclisiran. I have to give her the option and to take a consent to switch to inclisiran, and she was very excited. Said yes, great, let me switch. The other issue is that it's important to obviously follow the patient, make sure that she achieved the same 50% reduction with inclisiran on top of the other drugs, to explain to a patient you're not going to stop the other drugs, because some you might reduce the dose of Rosuva or something, but or other statins in your patients. But it's important to emphasize one, the issue of going into conversation and informed consent with your patient. 2, some of the patients think that, well, it's going to be 2 a year injection, 2 injections per year, and then I'm going to stop everything. I'm going to stop all other medications. So I thought to share this with you. There's a question from Professor Mustafa Shmeri saying, can we use a combination of inclisiran and PCSK9 inhibitor? Well, you always have intriguing question, Professor Mustafa. We don't have evidence for this. Any answers, Zuhair?
No, I don't have any. I think there's no study yet. There's nothing even. There's not even anecdote reports from using both.
Yeah. The question, would you have synergistic effect with both of them, or because you're already blocking the first step of making PCSK9, would blocking from a theoretical point of view, and after your excellent review of the mechanism of action, would they have a synergistic effect, or it would make a difference?
Again, we are blocking, we're blocking the protein upstream. So my guess is, as the medication becomes slowly degraded, probably there is a role for PCSK9 inhibitor. But if you're blocking it from upstream, and you're giving the dose as required, I don't think there's much protein left to inhibit or neutralize.
Yeah, and the whole advantage was lost. I mean, the whole point is, and the twist and the novelty is to give it twice a year. Maybe my expectation, and particularly after using the PCSK9 inhibitors, I'm sure many of you, when they used it, many of the oral medications, we were able to reduce the dose. Is that your experience as well, Zuhair?
Yeah, for definitely. I moved, most of the patients using PCSK9 inhibitor, and even tapered down the statin so that I don't deny them the benefit of statin. However, I don't need a large dose. Probably I need an intermediate dose. So PCSK9 does all the work.
As you already alluded to, it has been used, and inclisiran has been introduced in UK in high-risk patients, as we discussed, and has been used in some Gulf countries and United Arab Emirates. Some colleagues like Hani Sabur and others have shared their experience, that they have excellent experience with it. So it has been already approved by the Saudi FDA, and basically will be available very soon in many hospitals across the country. Dr. Mustafa saying you'll have great reduction with both medications, but not cost effective, obviously. And this is the other issue, the cost. Not only might not be effective together, it will defeat the whole purpose of being simple and avoiding a lot of injections at the same time, basically reduce the cost. Any last comments, Prof. Zuhair, before we conclude?
I think we are, again, this is very exciting times that we are facing, and this is another class, another mechanism of action that has both a very novel mechanism of action, a very novel regimen that I think is going to fit many of the patients' desire, because let's not forget that the patient is coming to your clinic, you give him the injection, so you make sure that this is the most compliant way of giving medication to a patient, that you do it in the clinic. So we're not going to be wasting any medication. The patient is coming before the injection, so you follow up and make sure that everything is well with the patient, so you can follow the patient as well. So I think this is very exciting. I'm myself very excited to use it in my patient. I think I'm going to have a lot of compliance because I'm giving it in the clinic, and down the road, I'm sure it's going to show very cost effectiveness.
Absolutely, I agree totally. Thank you very much for your great presentation. Very thorough, very impressive as usual, Dr. Zuhair Awan. I'd like to thank the audience, particularly Dr. Mustafa Shumeri, who always poses great questions and gets engaged as always. And thank you very much for Novartis for supporting such an educational event, and for the Saudi Heart Association for organizing this event and the organizing team. And please take care and stay safe. Thank you very much. Assalamu alaikum.
Wa alaikum assalam. Thank you, Professor Khalid. Thank you for the audience. And thank you for the support of.
Shukran.